entitled Tracking Treatment Plan Adherence and Including Measurable Outcomes. Hope everyone's having a good day, and we're glad you're part of this series of webinars. My name is David Eckert. I'm a senior consultant at CCSI Center for Collaboration and Community Health. This webinar is brought to you by the Managed Care Technical Assistance Center, MCTAC, and a bit of an overview of MCTAC. MCTAC is a training, consultation, and educational resource center that offers resources for all mental health and substance use disorder providers in New York State. Our main goal here is to provide training and intensive support on quality improvement strategies, including business strategies and organizational strategies, clinical practices, whatever help an organization might need to get ready for our managed care transition. So that is MCTAC's goal, and today's focus around treatment plan adherence speaks to just that goal. And we'll talk about its relevance and how making sure our clients are adhering to their treatment plans, how we're tracking that, how we're looking at progress, not only helps the clients, but really helps us provide services in a managed care environment. MCTAC is a combined effort by the McSilver Institute, specializing in policy and poverty research, and CASA Colombia, who are a nonprofit research and policy organization focused on improving prevention and treatment outcomes for those with substance use needs. Other partners include CCSI, us here, NIAPRIS, ICL, IDEAS, and we all form the MCTAC partnership. And again, my role here is as partnering with MCTAC as a CCSI employee of the center. So my areas of expertise relative to this webinar include behavioral health documentation, person-centered practices, and CQI initiatives. So talking more about this webinar series, this is second in the series of webinars that we're doing to help with this managed care transition. And the 6 topics cover effective clinical practices to improve outcomes and to set up people for success in a utilization management review process. And we'll review again more specifically what we mean when we're talking about utilization management in a managed care environment. The 6 applied learning discussions will include case examples, and so after this we're going to have a follow-up to it, so your questions and case-specific examples will be answered and provided next Tuesday. At noon, we have our OMH, we'll have an OMH question and answer session talking about very specific examples and how to apply these approaches to those examples. And the second hour, from 1 to 2, after our noon to 1 OMH hour, will be OASIS-specific case examples. So really we want to be able to apply these concepts to practice and to really give you something beneficial that you can plug in and use at your organization that goes beyond theory right to what's going to help you in practice. What we've developed here has included feedback from managed care companies, so we're really hoping that that informed feedback helps you meet their expectations. And at the end of this, we have evaluations so you know how to improve this series in the future. And we'd like to pause for a minute right now. There's a series of just 3 pre-questions that you could please answer that kind of gives us a baseline of what you know about today's material and will give us a sense of where you stand in regard to this. So if we could get some help setting up those baseline questions, you should be able to see those. The first question, I have a good understanding of what managed care companies are looking for when it comes to treatment plan adherence. And we've got that 5-point Likert scale attached to that, from strongly disagree to strongly agree. So indicate where you are as we start today. The second question, I have a good understanding of how to write very specific and measurable objectives in the treatment planning process. Again, same scale. How well do you think you do that? Strongly disagree to strongly agree. Very specific and measurable objectives, very important in the treatment planning process. And our third question, I have a good understanding of the specific data elements to be utilized in the CQI process to measure successful treatment plan adherence. So before we begin, how do you feel what level of confidence do you have in the measures that go into successful treatment plan adherence, and what can be monitored, what should be monitored, and how those conversations can go with our managed care partners? So we'll give you just a minute to answer those three questions, please. And hopefully we've given you enough time, and we will move on. Thank you for your feedback on those questions, because we really want measurable data ourselves for how valuable these trainings are, and really to get to what your needs are. And your feedback, of course, is essential in helping us learn the best ways to assist you. Okay, thanks. Looks like everybody logged in and we have those responses there. We will be offering feedback related to your responses as well. So stay tuned to that feedback. Okay, our learning objectives for this conversation on treatment plan adherence. First, to review the components of effective case conceptualization. That's where we began with our webinar series here in case conceptualization, and it's important to refer back to that to create the context for today's presentation. Second, to connect this conceptualization to treatment planning and the tracking and documentation of progress that's essential not only for communication with managed care, but it's essential for our communication with our clients. They need to see the progress they're making, and that measurability is very key to that. The third point, documentation with an eye for medical necessity and utilization management. So certainly we work in a system where medical necessity is paramount, and we want to make sure that we're hitting those highlights and talking about that within a utilization management context. We want to facilitate the integration of these concepts with case examples. So we'll talk about documentation examples, but again, I really want to emphasize that next Tuesday's case-specific conversations will really help us put it all together to the theory and specifics we're talking about today, and then bringing it to life with some real case examples that we'll be referring to on those Tuesday conversations. Our goal here, of course, is for you to have takeaways that you can utilize in practice. So what is utilization management? As we move toward managed care being full stewards of our Medicaid dollars, what is utilization management? That's the process by which managed care organizations decide whether specific healthcare services or specific levels of care of these services are appropriate for coverage under their enrollees' plan. So utilization management offers us those approvals for the services we provide. The primary purpose of utilization management is to ensure that the services are necessary, appropriate, and cost-effective. Again, they are stewards over our Medicaid dollars, and we want to make sure we're investing our money well and wisely, and that we're getting outcomes to show for the services we're providing. We also want to maintain fidelity and integrity of service while meeting these standards and requirements. Again, everybody is invested in the client benefit here. When the dollars are invested well and people are moving toward recovery in measurable ways, everybody wins. And the managed care companies are equally as invested, of course, in those outcomes. It's also required for reimbursement, so we wouldn't be here without reimbursement, so we want to know what that utilization management practice looks like, how to support it, how we do it organizationally and within the treatment of each client. And it's intended to be consistent with optimal care for clients and consumers. Again, it's win-win-win when the provider gets paid, utilization management approves the services, and the client shows measurable gains toward recovery. What is treatment plan adherence? So within the utilization management process, one of the things that the managed care companies are going to be interested in is how are we planning with people, what is the progress they're making, and how are we tracking by client, by caseload, and by clinic how this is working. How are we measuring outcomes overall? So treatment plan adherence is the degree to which our clinical documentation and client progress notes aligns with the goals, objectives, and interventions documented in the treatment plan, which is the agreed upon contract for care. I think for those of you familiar with the concept of the golden thread, where the assessment, in particular, the analysis and formulation at the end of the assessment is the springboard for effective treatment planning, recovery planning, and our progress notes do just that. They note the progress the client is making, and that thread of continuity of medical necessity of person-centered practice runs through all of those. You'll see this come to light when we're talking about treatment plan adherence. So the MCOs would like to see evidence that the treatment plans have been co-authored by the clinician and the client and demonstrate a clear understanding of how problems and functional deficits that the result from the diagnoses will be addressed. When we think of that formula for medical necessity, diagnosis is the cornerstone of that formula, but the diagnosis speaks to the functional deficits in the person's life. What are those barriers? What happens as a result of this diagnosis that treatment needs to be focused on to promote recovery? And a very important point about effective treatment planning speaks to the objectives. And objectives that specify measurable behavioral change help us capture the client's progress toward recovery. That will be emphasized in this discussion today. Objectives that are specific and show that measurable behavioral change are really vital to action-oriented treatment planning. And then at the point of the treatment plan reviews, we should provide measurable evidence of progress, that the approach to treatment, or if we don't have progress, that the approach to treatment has changed when progress is not being made. So we measure the progress being made, or we show that we've done some course correction and have changed our approach when progress is not being made. The progress notes themselves should clearly relate back to the treatment plan, include the key elements of medical necessity, evidence of person-centered practice, and speak to the client's motivation to change. The primary purpose of utilization management is to ensure that the services are necessary, appropriate, and cost-effective. And the way that we determine that they're a good investment is, again, by evidencing that quantifiable change. 3 F's. This basically conceptualizes an effective case conceptualization and treatment planning process. The first, in case conceptualization, we formulate well. We mutually develop a good understanding of what has happened, what are the client's strengths, but what are the problems and what specifically will treatment address? And also, I need to add, what won't treatment do? We need to focus it there. And the focus treatment happens in the treatment planning process, where we springboard from that assessment, from that mutual understanding of what the problems are and what we're going to do about it. We focus that in the treatment plan. And then treatment plan adherence, we're following the plan. We stick to what we've talked about the contract for treatment entails. That's the reason clients sign the treatment plan, is it's an agreed upon contract between the clinician and the client as to what will be addressed in treatment. And treatment should follow that plan. Or again, if the plan's not working, we should change the plan, but state why we're changing it. So the 3 F's: formulate well, focus treatment, and follow that plan. Utilization management terminology. So going back to managed care terminology now for a moment, what does this look like? What phrases, what terminology will they use from their end that we should understand as providers so that we can work effectively in partnership with them? The first is, what is a prior authorization request? That's the coverage for a new service, whether it's for a new authorization period when the approved upon number of visits has expired, or whether it's within an existing authorization period made before the service is provided to the enrollee. It's important to note here that for outpatient services, outpatient mental health, chemical dependency, etc., we do not require prior authorization to provide these services. Then we move on to concurrent review. The individual is enrolled in treatment. It's for continued, extended, or additional authorized services beyond what is currently authorized by the contractor within an existing authorization period. So if you've been approved for a set number of visits and visit type, if you feel the need to go beyond that, a concurrent review is the way that that decision is made and that agreement is made. A discharge review for inpatient in particular. This review occurs prior to discharge to assure that all the plans are in place. Now, as outpatient providers, we need to know that such a plan should be in place and that the managed care entity has helped assure that this was set up. A retrospective review takes place when on an individual or aggregate basis after the service has been provided. So we look back. How effective was the service? What change did we see? How was the investment of those Medicaid dollars for that service? Did we see the outcomes we hoped for? Were costs reasonable? Was level of care correct? All of these things are looked at in a retrospective review. And outlier management, very important in our managed care environment. Examples of potential overutilization and underutilization. In particular, managed care companies will be interested in, by diagnosis, what typically needs to be the intensity of treatment that matches that diagnosis, that matches that clinical presentation. Do we see that not enough service has been provided, or has too much? Have we seen little evidence of change, but a lot of service being provided? Outlier management looks at both ends of that spectrum. Why is treatment plan adherence and tracking important? So again, from a managed care perspective, during concurrent review and reauthorization, solid documentation will increase the likelihood that services will be authorized by your managed care organization. So we want to make sure we understand medical necessity, we're documenting change, we're making it quantifiable, we can measure it so that we can have these concurrent review and reauthorization conversations. In preparation for utilization management review, we must show evidence of progress throughout the course of treatment. In a minute, we're going to talk about some very specific ways to do that, very concisely, given that we only have an hour today, but we'll really try to outline what you can do, what you're probably already doing, or what you can do in addition to show that evidence of progress. The discharge review, again, from inpatient services assures that there's that plan in place for reentry in the community. Again, we need to know that such a plan exists on an outpatient provider basis. And it helps us prepare for this retrospective review to evaluate that overall performance. And it helps us with outlier management. So if we've documented effectively, and we'll talk about some ways that we can track entire caseloads and entire clinic functioning to identify this under and overutilization of services. Integrating case conceptualization with these utilization management requirements. So the first in the series of these webinars was on case conceptualization. How are we working together with the clients to decide what's needed, what our clinical approach will be, how often we'll meet, etc. So the assessment and conceptualization demonstrate the necessity of the service. We're coming up with a diagnosis. We're mutually defining what is the purpose for treatment that will follow, and how this treatment fits into the bigger picture of client recovery and any other services they may be receiving. And it speaks to that pre-authorization. Engaging client and selecting a treatment focus and in prioritizing goals demonstrates a person-centered approach and enhances motivation. Again, when we conceptualize a case, we're not necessarily doing this in a vacuum. We're doing this with the client so that they understand with us what treatment is about, and again, what treatment won't do as well. Monitoring progress on clearly defined behavioral objectives helps treatment remain focused. So that will help us say which objectives have been attained when we have a concurrent review conversation. Clearly defined and measurable discharge criteria set up at the onset of treatment, knowing what those thresholds are for discharge. What is that subclinical measure that says, hey, we're done here. There's light at the end of the tunnel, and this is when we'll know we're finished. This sets the stage for brief, problem-focused treatment with expectations for termination or plans to transfer care to other service providers in the community, to their natural supports, etc. These are integral to the discharge review process. But having that finish line clearly defined and measurable can really be motivating, and so the client knows when they're done. Documenting progress. So let's talk about the clinical documentation of progress. Hopefully, whenever possible, we're using evidence-based treatment approaches. We have a diagnosis. Research has shown that these specific treatment approaches, whether they be CBT, trauma-focused CBT, motivational interviewing, functional behavioral therapy, etc., there's an endless list of evidence-based treatments that we could be providing that tie right back to the diagnoses. How do we select our treatment approach, and how do we apply it based on that diagnosis? We'd like to do that whenever possible because it's been proven to work. So then we look at the objectives in the treatment plan. We know they represent the specific behavioral changes and steps toward recovery in measurable terms. The progress notes then will show, referring back to these objectives in the treatment plan, these evidence-based interventions. So if it's cognitive behavioral therapy, then we will show evidence in our progress note of CBT and the client's response to it. What steps has the client taken towards goal acquisition, toward their recovery goals? What challenges or barriers have they encountered toward these goals? And what is the need for continued services? This shows the medical necessity of future treatment. If there are still those specific functional deficits, what behaviors does the client have to engage in to reduce those functional deficits? And again, in a person-centered world, these conversations are led by the client. Progress should be continually monitored throughout the treatment and, of course, should be quantified whenever possible. I know that's been repeated often today, but it's such an important point. Establishing the medical necessity of services. All Medicaid dollars go toward medically necessary services unless we're talking about waiver type of services, but for the purpose of this discussion, we're talking about the cornerstone of medical necessity. These symptoms support the diagnosis and lead to these functional deficits in a person's life. A standardized and managed care approved functional assessment can help demonstrate this. So as you're using your template for your assessment within your organization, how does that align with what the managed care organizations you contracted with expect from your organization? Perhaps it covers everything they need. Hopefully it does, but if not, you can have conversations with them about this. Treatment targets these functional deficits to reduce or eliminate the impact of the diagnosis, and of course this is established in the treatment plan. Your documentation will include the fact that the treatment has been ordered and prescribed by an appropriate individual, by a credentialed individual. Just refer to your regulations. They'll be very clear about what credentials are needed. This service should be generally accepted as effective for the mental illness or addiction being treated. So the approach used should have worked in other contexts. Again, this speaks to the importance of evidence-based practice. When we know it's worked with folks with similar diagnoses, we can expect if we apply it with the fidelity of practice that it will work with our individuals. Individual must be willing to participate in treatment. They must be attending and willing to move toward their goals. This is a standard of medical necessity, that they are actively participating in treatment. And we must show some benefit from the services being provided, that they are in the correct level of care and that some gains are being made, or at least that they are not falling back to a pattern where clinical outcomes were worse and where we saw inpatient stays, et cetera, relapses, et cetera. So they must be benefiting by showing progress or at least not falling back to a previous, more acute level of symptoms. And of course, there must be evidence of the client's active participation in treatment for treatment to be medically necessary. The managed care organizations want to know the basic demographics as well associated with the diagnoses and what are the individual's psychosocial needs. You can see how these important factors complement everything we're doing with medical necessity. And we also want to know that there aren't ethnic and racial disparities in the treatment of folks. If we identify such disparities, we should know what we're going to be doing about them. So measuring change over time. We have evidence-based practices that are dictating the use of specific measurement tools to evaluate progress. Administer these instruments with fidelity outlined to the model. So as you're applying these evidence-based practices, we can't emphasize enough the fidelity to the model. They've given you tools, the ones referenced in the research, the ones that you learned about in your trainings and how to apply these evidence-based approaches. Apply these instruments, have the clients fill them out and know what the measure is, where you start at baseline and where you are at different points in treatment. There are also level of care determination tools, rating scales, and standardized interviews that can help facilitate these conversations about measurable change. In the OASIS world, we have the locator, which was collaboratively developed with managed care and provider organizations. Speaks to the level of care and is it effective. In the DSM-5, we have the cultural formulation interview, very specific outline of an interview process that tells us where we are at baseline. And on the CTAC website, if you're not familiar with this, sign up. It's all free. They have the output to outcomes link here where you can filter by OASIS, substance use, type assessment tools. You could filter behavioral health tools, physical health, et cetera. Of course, we're focusing on behavioral health treatment here, but you can find free, accessible, reliable, and valid outcome tools on this website and really get your measurable outcomes from there. So administer these at least at the time of the initial assessment, part of the assessment process, and at the time of the treatment plan and treatment plan reviews. Now that's kind of at a minimum. We want to have measurability every 90 days or so, or when, based on the level of care you're working at, the program you're working in, when you do your natural review. I'm a strong believer in collaborative documentation, that we can do these instruments with clients and show them measurably where they stand regarding, in comparison to where they were at baseline. Progress feeds on progress. And we know about the Hawthorne effect from research, where when we're measuring something, it tends to improve because folks know it's being measured. So let's use that. Let's use these outcome measures and the motivational enhancement capabilities that they provide for us. So re-administer, again, as often as feasible, but at least at the point of each treatment plan review. Some examples of these, we have Beck's depression inventory, anxiety inventory, the bipolar affective disorder dimensional scale, the children's PTSD symptom scale, the CAGE questionnaire, substance abuse subtle screening, the SASE, and many more. This is just a small fraction of the ones available for free on that website. There are others that you can purchase at a fee, but they're all identified on the website. But that will give you a great start toward looking at how to use measurable tools and what's out there. Treatment plan objectives, promoting behavioral change within sessions. So let's be specific about what we're talking about here. We've started with a baseline measure. We have a tool specific to that diagnosis filled out. We have a quantifiable result from that, so we know where we started at baseline, and it speaks to that diagnosis from the assessment. Now we're writing objectives in treatment plans, and as a consultant for the past year, working all across the state, I've really found that well-written objectives are the most important component of effective treatment plans. It's probably the most challenging part of treatment planning, but the most important part of treatment planning. Adams and Greeter tell us they use the RUMBA, realistic, understandable, measurable, behavioral, and achievable. So do they meet that criteria? They use that acronym. Another one, different way of saying pretty much the same thing. Are they simple, measurable, achievable, realistic, and time limited? So what are those baby steps? What is that next measurable step, that change in behavior we're going to see the client make between sessions? What are they going to do about the problem that is specific, behavioral, and action-oriented? Then when these objectives are part of the plan, they can be crossed off the list. I think we can all relate that when we make a to-do list, it feels pretty good to cross things off that list. Well, the same is true of the people we work with. When they've achieved that next step and there's a behavioral outcome and something they've been successful with, we can cross it off the list and show treatment that has a motivational enhancement quality and really shows progress. You can also see how these would be important components in our conversations with managed care organizations. We can talk about objectives that have been achieved. This also places the onus of change on the client. It's all about the behavioral change that they engage in, with us as being a conduit toward recovery to help them be action-oriented and achieve these objectives. The biggest, I think, most challenging thing is to write them in clear and succinct ways. So here's just a few examples, a snapshot of some well-written treatment plan objectives. Again, what are these measurable behavioral steps that meet either the RUMBA or the SMART criteria? Jill will obtain an AA sponsor of her choosing within the next 3 months. Pretty clear, shows that she's achieved something. In the next 90 days, Stephanie will identify at least 3 ways she can establish healthy interpersonal boundaries with her family. Clear, measurable, behavioral. It shows what she's going to do about it. Over the next 90 days, Manuela will exercise for at least 30 minutes at a time, 3 days a week. We all know about the benefits of exercise, etc. Let's say that in helping Manuela overcome depression, she came up with this as a person-centered goal. Well, let's make a very succinct objective with it. And if she wants to start it 1 day a week, etc. The point here is that we've made something measurable and achievable. We can cross that off the list when she's successful with it. Between now and January 1st, Dexter will arrive at school on time and attend for a full day on at least 4 out of 5 possible school days. Very clear, very measurable. Now, just to step back for a minute and contrast these with some, well, they're really not objective, some of them, but they're not well written because they're not focused and measurable. John and parent will attend psychiatric appointments with psychiatrists. This is an actual objective that I've come across. The point is not to, again, point out poor documentation, but again, to contrast this with what looks like a well-written objective. And by the way, attending appointments is an intervention. It's not an objective. It speaks to what we're prescribing. Objectives do not speak to what we will do. They always speak to what the client will do. Mary will report that she has insight into her depression and her mood has improved. Okay, it's getting there, but how will we see that behaviorally? How will we know when there's insight? How will we know when mood has improved? Again, these could be more focused and clearly written to show that we can cross them off the list. So well-written objectives are the heart of a good treatment plan and speak to those behavioral changes, and we can monitor how these behavioral changes have led to measurable changes at the point of treatment plan reviews. That's how they work together. The managed care organization rationale for tracking treatment plan adherence. So let's get back to this from a managed care perspective for a second. Providers need a template so that we can share details regarding the client's treatment needs and progress. We've just talked about ways to measure them, both in terms of the actual tools we can get and achievable objectives. But how are we going to track these? So developing a template we can use by client or by caseload and getting some structural organizational help with this that we'll talk about in a minute is very important. The managed care organization and the provider will then work together to ensure that the client's needs and the standards of medical necessity are being met. So we've documented these things, and we can refer back to them to have a conversation about them. The managed care organization and provider collaborate to ensure that clients are treated at the least restrictive and most effective level of care. Maybe what we see with the lack of progress is that the level of care does not match. Maybe we need to move from clinic up to pros, or maybe we need to move from OASIS outpatient to intensive outpatient, etc. So let's have a conversation about, does the level of care match the client's needs? The managed care organization and the provider will work together to ensure that transitions will go smoothly as well. So if a level of care change is indicated, how could we work to make sure that we're partnering with the managed care providers to have these level of care transitions go smoothly? We have a warm handoff and engagement at the next level of care, whether that's moving up or moving down in levels of care. The managed care organizations want to know, how does this treatment fit in the big picture of recovery and other services being received? Is a larger change being called for? So let's get back to the agency technological tools and supports needed. So as we have this conversation, you are either already in a fully managed care environment, a partial managed care environment. Almost all of you, I would venture, are working with managed care on some level. So how do we organize ourselves as an organization, as agencies, to be able to track this treatment plan adherence and to show measurable progress? We already know it's a lot to keep up with our duties on a day-to-day basis. So having a structure to assist with this is very important. We need our staff understanding utilization management processes and goals and how to clearly communicate clinical data requirements to the managed care organizations. If we have other than clinical staff having these conversations, do they know how to speak to treatment plan progress and how to reference these measurable attainments? Whenever possible, agency utilization management staff have access to the managed care provider manual. In these provider manuals, they will lay out their expectations for procedures for pre-authorization and ongoing authorization of services. They'll tell us what information they're looking for. Documentation templates are very important to identify treatment data points for tracking and reporting purposes. For those of you with electronic medical record systems, hopefully they have report-generating functions that can assist you in doing this by client, by clinician, and by clinic. So we can break it down, hopefully by diagnosis. Quite often that's a decision point for pulling data. How well are we doing with treatment plan adherence broken out again by client, by clinician, and for the whole clinic as a whole. The effective integration of these spreadsheets and databases between utilization management and CQI teams. So we have our folks talking to our utilization management people. Will be talking to the managed care organizations. We also want to have a recursive, circular, continuous quality improvement practice. Plan, do, check, act. How are we doing? What are we doing? Is it working? What are the measurable results? And how do we let our clinicians know about that? How are we giving this information back to their teams? And we want to link that with billing and coding functions for reporting purposes, because clinical viability relates to fiscal viability. Soon we're going to be moving past the fee-for-service day and age where we simply got paid for providing a service. We're moving toward, we're not paying for programs anymore, we're going to be paying for outcomes, and showing that we're getting these measurable outcomes will be very important to our future sustainability. So embedding these practices within your organization, having your clinic be able to, your clinicians rather, speak to your billing people, woven into your utilization management and CQI practices will be very important structurally. So how will those evaluation templates look? How will they be applied? What will be the, evaluating the adherence to these treatment plans? What is the content of these treatment plan reviews? So we know treatment plan reviews are completed and appropriate signatures need to be obtained within a 90-day framework. The overall goals then are reassessed, and we've talked about the need to reassess and to do, again, apply a measurement tool at the point of a treatment plan review. We want to show that measurable progress has been shown, and we want to show those objectives, those really clearly written objectives have been well documented and achieved. The client's view of their overall progress with each objective is documented, and quotes are utilized whenever possible. In my travels, I've seen clinical documentation that does speak to what the clinician feels about progress, but it's really an enhancement. It's an essential quality, more than an enhancement, that we know how does the client think they're doing. And this applies to adults and children. What do they say about treatment and how it's working? That's essential. They are, in a person-centered way, the people that are driving that bus. We want to make sure we're capturing what they say about what's working and what's not working. Whenever possible, again, these valid and reliable outcome measures are used and related to the evidence-based practices utilized and are administered and scored as part of that treatment plan review process. Then we can document that measurable progress toward discharge criteria. If the decision is made for treatment to continue, if we're still seeing those functional deficits, that our discharge targets have not been met, we're not at those subclinical levels yet, then the rationale for medical necessity and continuing treatment is documented. Why are we continuing treatment? In a very specific framework. Create an alternative plan for treatment if the client is not making progress or is becoming more symptomatic. So let's clearly state what's working, what's not working, what does the client say about it, and how have we course corrected based on that feedback. Aggregate tracking of caseload. So moving from the treatment plan review specifics to an entire caseload for a clinician. Quarterly or monthly reporting from documentation. This is where our electronic health record, medical record systems can come in very handy. Hopefully they can pull these reports for us. We'll know the total number of clients for that clinician active in treatment, their length of stay by diagnosis and diagnosis type. For example, we can separate thought disordered, mood disordered from depressed, anxious, co-occurring, etc. So what are our diagnostic categories? How have we compartmentalized those? And how do we show length of stay according to those categories? We have show rates by client, clinician, and diagnosis. Very good to look at who's got really good show rates and what are they doing? And what is it about that clinician that's promoting really good show rates. Does that speak to the diagnosis, or is it something else happening within the treatment? Is it one of those practice-based outcomes, those things that some clinicians do that just seem to get results that we want to measure as well? We want to know the percentage of clients completing all or most treatment goals and objectives. So we've got these definable objectives. How are the clients doing by clinician at achieving objectives? This can speak to how well those objectives are being written and whether we're seeing that stepwise progress. We want to know what percentage of clients have been successfully discharged. Who's achieving all or most of their treatment goals and getting to that endpoint, that subclinical level, that discharge criteria? What percentage of clients have been lost to contact and dropping out of treatment? Frequently, we study the modal number of a treatment episode, and we find out most clients come just once and don't come back to treatment. When that's happening, why are they lost to contact? What happened with what's happening in those episodes, and what can we do to engage? And again, those clients that were seen once and never returned, that's an important story to tell. We don't know if they got what they needed and moved on, or if something happened in the assessment process that they didn't feel met their needs, etc. But let's get the story behind that number. So, putting it all together here, operationalizing treatment plan adherence in practice. This is bringing together your clinical team, your financial team, your utilization management team, and your CQI staff, having them all understand that it really works best when it's working collaboratively. The clinical staff are utilizing a utilization management template to accurately document key utilization management data points, and they can efficiently partner when they're having these conversations with MCOs to share relevant treatment information. For example, what are those measurable gains? What objectives are being met? What does attendance look like, etc.? Who is successfully completing treatment? All those points we just covered. The financial staff track and communicate status of approvals and denials to the clinical team so they can problem solve with the MCOs as needed. Remember, they're going to be evaluating how is treatment working on behalf of our covered lives. What are these approvals and denials telling us about how we can better partner with MCOs to meet client needs? The utilization management staff understand the relevant clinical documentation and the data points. So if we have our conversation coming from staff that are other than the clinicians themselves, can they have these really well-informed clinical-like conversations to speak on the clinician's behalf with the managed care organizations about what is the evidence that the client is gaining from the treatment? And your CQI team pulls this all together. So we're looking at plan, do, check, act. What are our CQI goals here? Maybe we start with a goal on reducing wait times or client engagement, or we see a co-occurring population. So what are our major CQI efforts? And what are we reporting about these efforts back to managed care organizations? What exactly are we measuring, and what are the outcomes associated with those measurements? Other examples include MCO approval rates, overall show rates, productivity of clinicians, etc. We need to be fiscally viable as well to be able to continue providing services. And we can share with management of all departments to drive the agency's CQI processes. Another real positive here is to have visuals to go with those reports. Data is great. Visual data really is more impactful as well. The MCOs want to know, can I obtain summaries on both individual clients and clinic performance in general? So when we're having these conversations, can I get those summaries from your utilization management folks to be able to talk about how our partnership is working on behalf of these clients that you're serving? So moving on from here, we have about 10 minutes left, so let's talk about where we go next. Hopefully, if you have questions, you've written those down. You can email those to us. We will answer them. Hopefully, we will also get to questions you have about how this is applied to practice when we have our active learning discussion next Tuesday. So supporting case conceptualization as a supervisor. That is our next webinar. That will be on December 1st of this year. That webinar will build on the two that we've had, today's webinar and case conceptualization, to talk about concrete strategies to increase reliability and validity of case conceptualization. So looking back on how we've worked with clients to identify their needs, how are we doing the concept mapping and the chalkboard case conceptualization exercises? How do we support these as supervisors so that we're not just talking about the theory, again, we're really embedding this as a change in practice. Conceptualization should evolve as information is gathered. Making use of existing data, we will also talk about that. Previous assessments, work with care manager assessments and those inter-array assessments they'll be completing or are completing, and how to work with that fantastic psyches database and the great reports we get from that about what's happened in the last 5 years. What are the flags these folks are hitting in these psyches reports? How do we support LGUs, either as service providers or as those that oversee all of the service providers in our counties and others? So there's a lot of existing data out there, but how do we use data to drive practice? And how do we really operationalize the use of data to drive practice? That's how we'll know we're functioning on all cylinders in a managed care environment. We want these data feedback loops to track whether adjustments to the treatment plan need to be made. So again, we're getting back to that client and clinician specific information. So we'll be talking about that and highlighting how all these come together for supervisors to support these processes. We intend these webinars to build on each other and to make sense as they link with each other as you move forward. They are recorded and archived, so they're on the MCTAC website. If you've missed a webinar, you can log on and make sure you get caught up with what you need. They really might make really good staff meeting use for professional development as well. So feel free to use these as you feel they could support your efforts. In summary, healthcare reform is here to stay. Managed care is coming in. We'll be fully managed care activated by the year 2017. So this is the environment we're working in. Utilization management is part of this environment. These requirements fit well within our framework of high quality care. Everything we're talking about here promotes recovery, promotes the measurable benefits for the clients we serve. Everything is working toward that end. Treatment plan adherence and including measurable objectives help increase client motivation as they gain increased understanding of the purpose of treatment and gain quantifiable evidence of change. Again, success breeds success. And I would also argue the opposite side of that, that a client that doesn't ever see their treatment plan change, doesn't ever have any evidence of progress, might be dropping out of treatment and might not be that invested in treatment. But that aside, when they see success, when they see gains, it tends to elicit more change. Having clear discharge criteria, repeating this theme, this provides hope by signifying an endpoint for treatment. Whether it's a medical treatment or a behavioral health treatment, we all want to know what better looks like. If you're getting treated from your primary care physician for hypertension, for high blood pressure, well, what does normal blood pressure look like? And how is what I'm doing with diet and exercise and medication helping to drive my diastolic and systolic measures to optimal medical levels? So what's my measurable evidence that this is working? Well, we are medical professionals as well. We want to show measurable evidence that what we're doing is working. So these changes in practice do require upfront work, We're talking about what the clinicians will do, what the supervisors will do, the operational structures for utilization management and CQI practices. This is a big lift. It's a lot of work to modernize the way we work to be managed care ready. But it's important work. It's good work, and again, it's all directed at the benefit for the clients we serve. In the long run, they're a solid investment as they support the foundation of our recovery-based service system. So acknowledging this is a lot of work, and we appreciate that you are on the webinar today to talk, to listen a little bit more about how to do this work and be successful with it. The next steps, identify a utilization management liaison within your organization. Who can speak that language clinically and help tie in these reports and this structure? This UM liaison should review provider manuals by the MCOs to know what are they looking for with terminologies and expectations to disseminate information within the organization. If you're a supervisor, consider incorporating concept mapping and consider facilitating the greater integration of these ideas. And again, 12/1, we're going to have that webinar. Our next step here, again, just to reiterate, is next Tuesday, 11/17/15, case-specific discussions about applying these principles. OMH will be noon to 1, and OASIS from 1 to 2 p.m. So 1 hour each. Please involve yourself in those discussions. For those of you working with a co-occurring population, which is many of us, you may want to attend both of those. Another little plug here for the supporting case conceptualization as a supervisor on 12/1. And always seek consultation and support for enhancing health information technology capacity that streamlines your documentation processes. A lot of times external support from those that have been successful with this can really help build that capacity within your organizations. Before you go, one last little business item. We did our pre-test at the beginning. Now let's do a post-test. We appreciate your honest and objective feedback here. So, related to the same 3 questions after this hour-long discussion, I have a good understanding of what managed care companies are looking for when it comes to treatment plan adherence. Please let us know. Hopefully this webinar has helped your understanding of that. If not, let us know that too. I have a good understanding of how to write very specific and measurable objectives in the treatment planning process. Let us know how that worked out for you. And the third question, I have a good understanding of the specific data elements to be utilized in the CQI process to measure successful treatment plan adherence. So that big organizational level, how did your understanding change, hopefully gained from the information from this hour-long presentation. Thank you very much for answering these questions. We really appreciate your participation with us and look forward to having you involved with our future webinars. One last note here, if you have questions, this slide here, mctac.info@nyu.edu. Please send your questions and use in the subject line treatment plan webinar, and we will make sure these questions get answered for you. Okay, thanks so much for your participation here. We appreciate it. Hopefully we'll see you log back in on November 17th, next Tuesday. Again, OMH case specific at noon, OASIS case specific at 1 p.m. Thanks again, and we appreciate your participation.